that. And we are going to be officially recording the program this evening. So without further ado, I'm going to turn the Zoom room over to Elise, and thank you again for being with us.
Thanks so much, Jude, and thanks to Jude and Nancy for asking me to do this tonight. I think Nancy was a little bit hesitant because I think she thinks we actually are still 30, which would, even when we were 30, we'd still known each other a very, very long time. But no, we are actually 50 something now. And so, you know, this is our jam. This is what we're thinking about. So it's a pleasure to be here and give you some of my perspectives on menopause as a working gynecologist. As my career has grown and I've aged with it, and I started off my career with a pretty heavy interest in family planning and contraception, and that's moved more into menopause these days. But back in the day, I used to give a lot of talks on family planning, and I remember my father as a pharmacist attending one of them. And I think my mother was always quite jealous that she never got to hear me in action. So it's wonderful to have them here today. If you scroll through, you'll find my folks. And for those of you in the States, you may not realize we're still pretty much in lockdown. So this is actually the first time I've seen my parents in quite a long time. So that's kind of a bonus too. So anyway, it's great to bring everyone together. You know, one of the side effects of COVID, there's some slight upsides, is having the opportunity to be creative about how we meet and how we come together and how we share ideas. So today is all about menopause. There is a chat box on the side, and you can enter questions as they come up as we go. Nancy will be moderating that, and my hope is to get to that at the end. So we've got about half an hour, 40 minutes of chatting, and then hopefully a good 20 minutes to go through some questions. This is a huge, huge topic, and I'm sure I'm not going to cover everything that everyone wants to know. So hopefully we'll have some time at the end.
Hi, how are you? Good,
okay.
thank you.
So to get going, and just again, if we could remind everyone to turn their mutes on. This is what I propose to do tonight. I want to talk about menopause, and I want to give you a definition so you know what it is that we are talking about, and touch a little bit about peri and postmenopause, where that fits into the definition, and also what that means and what we experience. I want to give you a bit of a history lesson about hormone therapy, because hormones are this big scary word and everyone has a lot of questions about it. There's a lot of confusion out there. And I want to talk about how we can approach treating menopause, be it with hormones or without hormones. And then at the end, and this part's really awkward with my parents on the call, we're going to talk about genitourinary symptoms of menopause, or what we call GSM. What happened to my vagina? Why do things change, and what can we do about it? And lastly, I'm going to leave you with some resources so that you'll have a place to go if you've got more questions. Okay, so getting right to it. So what is menopause? Menopause is defined as the time of the last period. So it is on average somewhere between 51 and 52 for North American women. Normal is anywhere from 45 to 58, although I have seen later. And younger, between 40 and 45, is actually still considered normal. It's early, but it's normal. There's nothing wrong with going into menopause in your early 40s. But the interesting thing about menopause is it is a point in time. It's the time of your last period, but you don't know it was your last period unless you've gone a year without a period. So it's a diagnosis of retrospect. And a year is something of an arbitrary timeline. I've definitely seen women who have gone more than a year and then had another few periods, and then they get back into starting the clock for menopause. Perimenopause is the time leading up until that last period, and it can be for several years before the last period. So it's not the same as premenopause, which is all the years before that. From puberty until menopause is premenopause. Perimenopause are the years and the changes leading up to menopause. So if you think about the math of all that, it means these days, as women live into their 80s, we spend about a third of our life in postmenopause, after menopause, and that's pretty significant. So is it natural? Is it normal? Is it a problem? Is it something that needs a solution? And there's many different perspectives and ways to answer all of those questions. And I would argue that all of the answers to those questions, being It's completely natural. It doesn't require, it's not a problem. It doesn't need a solution to it's, yes, it's natural, but it's a problem. It needs a solution, and everything in between can be considered feminist answers to it. And the solutions that have been proposed as feminist solutions, have been proposed as health solutions, have been proposed as paternalistic, misogynistic solutions, and the whole gamut. You know, a lot of the original research was done by men because men were the researchers at the time. And so there's a perspective that says this is men telling us what to do with our bodies, as they have for much of our lives. There's a feminist perspective that says take control of your life and control your own experience, which can be interpreted as being very pro-treatment and also being very anti-treatment, because the treatments come from the pharmaceutical world, and there's a lot of hesitancy around that, understandably. The bottom line is it's your choice in terms of how you approach it. But the one thing I would ask you is to do it with some understanding and some knowledge, and ensure that that knowledge is good, grounded knowledge from good sources. Okay, so let's understand a little bit about what menopause is. Our ovaries produce estrogen and progesterone. That starts to happen with puberty. Those are the two main hormones that they produce. And the estrogen is produced when the ovary is getting ready to release an egg. So if you think of it, our bodies, every single cycle, when we're having periods, is getting ready to get pregnant. We produce an egg, and that estrogen thickens the lining of the uterus so that it can accept that egg in preparation of a possible pregnancy. Once the egg is released, the progesterone is produced, and that progesterone is needed to support that thickened lining if there is a pregnancy. If you get pregnant, you need progesterone on board in the early phases. If you don't get pregnant, then that progesterone level drops, and it's the drop of the level that causes that lining that's been so plumped up and thickened and ready to accept a pregnancy that sloughs off, and that is your period. That is the bleed of your period. So what happens in menopause is that the ovaries completely stop producing eggs and your estrogen levels drop. And it's the drop in those estrogen levels that causes a symptom of menopause. Now in perimenopause, in the time leading up to your last period, your ovaries will still produce eggs and follicles on and off. It's a bit inconsistent. They might start to produce a follicle and the estrogen gets produced, but they don't actually let the egg go. And so your estrogen levels fluctuate, as do your symptoms. And even after menopause, there are small amounts of estrogen produced in our body, particularly in our fat cells. So women who are bigger have more estrogen circulating, but the majority of it comes from our ovaries. So the thing I always get asked is, well, isn't there a test? Can't I know if I'm in menopause? And the problem is that the test isn't very reliable. It's reliable in that when you measure this hormone, it's called follicular stimulating hormone. It is accurate in that moment when you test it, but the results fluctuate almost daily. And especially when you're going through perimenopause, your FSH can be super high and then super low and all over the map. So it doesn't actually stay high, which is the menopause range, and stay there until menopause is fully established. So the test is not helpful. The next question is how long, if you have symptoms, how long are they going to last? And it's really going to vary a lot from person to person. About 50% of women or more may have hot flashes that last for more than 5 years. Now, they might not be as intense several years out, but they can still last. And there's a small group of women who will have significant symptoms all the way through their life, their postmenopausal life. And in terms of who gets symptoms, 15% of women are pretty lucky and have almost nothing to speak of. 15% of women have really severe debilitating symptoms, and I mean debilitating. And the bulk of us are somewhere in the middle. 70% of women have a variable severity of symptoms. Perimenopause is those years leading up to the final period, and it can go on for a good 10 years. Some women have nothing. Some women start to have changes 10 years prior to their last period, and they keep thinking they're about to be in menopause, but they still have years to go. And what's happening is that our ovaries stop responding as reliably as they did when we were younger. And so our estrogen and progesterone levels are not as consistent. And what that leads to, first of all, is a change in our bleeding pattern. So the one thing I will say to women is that your periods are very likely to change as you approach menopause. And that's all I'll commit to, because how they change can be anything. They can be shorter or longer. They can be heavier or lighter. They can be more frequent. They can be less frequent. They can be more painful. They can be less painful. We typically think of perimenopause as the periods getting awful, and they very often do, heavier, more painful, etc. But that's because we don't hear about the women who actually start to have lighter periods and everything just gets a little bit better. So it can go both ways. The other thing that can happen is all of the other symptoms associated with our periods can start to get a little more intense as well. So PMS symptoms can be more intense. You can see some more mood issues, breast tenderness, what we call brain fog, and just not really having the same ability to concentrate. And along with all of that, you can have typical menopausal symptoms because when your hormone levels are low, you get those symptoms. So what are those symptoms? And this, I find this is such a depressing slide. And every time I put it together for a talk, I feel like I'm adding more symptoms to it. But this is sort of what we're thinking about with menopause. This is what women see and feel. So the big thing that everyone sort of thinks of are the vasomotor symptoms. So that has to do with the hot flashes or hot flushes. You can use either word, and night sweats. And that has to do with our thermoregulatory status. And there's things going on in our brain that impact how hot we feel on the inside. We can also have sleep disturbance. And I think there was an understanding previously that you had night sweats, the night sweats woke you up, and therefore your sleep was disturbed. But there's actually an element of sleep disturbance that's entirely related to menopause all on its own without the night sweats. The genitourinary symptoms, that includes vaginal dryness, pain with sex, and also bladder problems. So bladder irritability, feeling like you need to go all the time, and more frequent bladder infections. Then you can have joint aches. You can have palpitations where you feel like your heartbeat's going rapidly, which can lead to almost a symptom of a panic attack. There can be memory loss, anxiety, mood changes, irritability, fatigue, which can be a symptom of not sleeping well or can be a symptom all on its own. Poor concentration, decreased sex drive, a change in our metabolism. So we tend to have more weight gain after menopause, and also a change in our weight distribution. So even if the numbers stay the same, you feel like you have more of a gut, whereas before, if you put on weight, it went to your breasts and your bum. Now it seems like it's more in your center, like you have a little bit of a pot belly. So that's what we see and feel. But then there's all the stuff that we don't see and feel, and that has to do with our bones and our heart. So after menopause, we start to lose some of our bone mass. People talk about it as bone thinning, and it can lead to osteopenia and osteoporosis. So osteopenia is just sort of a milder version of osteoporosis. But your bones are more thin, and we actually lose a lot of bone mass in the few years that menopause starts, and then we start to lose it more slowly or slower as years go by. Men also can have osteoporosis, and they can also lose bone mass, but they just lose it slowly over time, or we have this sudden drop around the time of menopause. And what that leads to is a higher risk of fractures. So if your bones aren't as strong, if you fall, you're more likely to break something. And then the other big area is heart health. So estrogen has a protective effect on our heart. And that's why you think of, men, we think of men when we think of heart health, but women start to catch up to men in terms of the rates of heart attacks and heart disease as they get older, because we lose that protective effect of estrogen. Heart health is also influenced by other changes such as weight. And if we gain more weight, that also has an impact on our heart health. And I think it's really important to remind people that heart disease is the leading cause of death in North American women. It's more than all cancers combined. So we're going to talk a little bit about breast cancer, and certainly that is something we need to think about and worry about for all kinds of reasons, and hormones might be one of them. But heart disease is a much bigger killer. So what do we do about it? We're going to talk about treatments, but before we do that, I think it's important to remind us of the things that we already know, but there are lots of things we can do with our lifestyles that will keep us healthier. So obviously smoking, watching our alcohol intake, and also various drugs, prescription or non-prescription. Important to point out, and this doesn't necessarily get talked about very much, but 2 drinks per day increases your breast cancer risk about 60%, or the equivalent of about 1 to 2% per year, which is at least twice as much, if not more, than hormone therapy might ever cause. So just to keep that in mind. You want to stay healthy with your eating and healthy with your weight, because we know obesity is linked to breast cancer risk as well as uterine cancer and heart disease. And we want to keep exercising. And specifically when we think about exercise, we want to do exercise that helps stimulate the bones. So anything that puts pressure on your bones, like walking or running or weightlifting, yoga, when you're holding your body up, that sort of thing, that is great for bone growth. And then specifically for your heart, you want to think about things that make your heartbeat race. So if you're a walker, that's great, but make sure you're doing a good fast walk and get your heartbeat pumping a little bit. That's what you need for your bones. And also getting adequate calcium and vitamin D for your bones is important too. Other simple things we can do for symptoms. If you are experiencing hot flashes, you want to think about what the triggers might be. And these are the common ones. Caffeine is a big one. So depressing. I'll take my hot flash with my latte any day. Alcohol and specifically red wine can be a real trigger, which you might not have realized yet, but think about that if you're having hot flashes while you're having some red wine. Spicy food and hot beverages and soup can also trigger it. And then if you dress in layers, it's just really easy to very, casually cool yourself down if you can take some layers off. There's lots of fabrics now for bed sheets that can help keep you a bit cooler, and having a fan handy is very helpful as well. Okay, so that's sort of the non-medical stuff that we can do, but let's get into the meat of it, which is hormone therapy. So I want to talk about what hormone therapy is, and even this phrase hormone therapy. We don't say hormone replacement therapy anymore. It's kind of it's a therapy. It's not replacing anything necessarily. It is treating a problem. And that's why we call it a therapy. But you've got to remember there's many, many different hormones in our body. And we are really just talking about estrogen and progesterone here. There's tons of other hormones, super important on all kinds of levels, but this is specifically estrogen and progesterone. That's what's at play. And it's really the estrogen that's going to treat your symptoms. And if we could take estrogen alone, we probably would. It might be a tiny bit safer for us. But the problem with estrogen alone is that it stimulates the lining of your uterus, and that can lead to uterine cancer if it's not balanced. So it's balanced by progesterone. And as long as progesterone's there, you have no increased risk of uterine cancer, but you need the progesterone. Unless you don't have a uterus anymore, and then you don't. And you can give the estrogen and progesterone by mouth as a pill, but you can also give it through the skin, through a patch or a cream. And you can also give estrogen through the vagina, which we'll talk about in a sec. So I want you to kind of understand where we're at with hormone therapy. And this really centers around something that happened in the early 2000s. So hormone therapy, and specifically estrogen, has been known for a very long time to, by far and away, be the best treatment at managing the symptoms of menopause. No one will argue that. That's pretty clear cut. It's not up for debate at all. But through the 70s and 80s and 90s and ongoing, but certainly in the 70s and 80s, there were lots of studies that suggested that women who took hormone therapy seemed to live longer. And so we wanted to understand why that was. And it looked like it had to do with having a lower chance of having a heart attack and dying from heart disease, and also because their bones were healthier. So that seemed to be the relationship. If you took estrogen, your heart and your bones were healthier. But there are a lot of questions that still remain about the relationship of hormone therapy to breast cancer and also to stroke risk, so having blood clots and strokes. So there was a very, very large study that was designed. It was called the Women's Health Initiative, or the WHI study. It was supposed to run from 1990 to 2004, and it was designed to show how hormone therapy helped and to help prove that women lived longer and healthier. It was taking those questions and trying to say, yes, we think this is true. Now let's actually show that it's true. And that's what it was all about. Now, what was the problem? In 2002, so a couple years before the study was supposed to end, they had been doing interim analyses and looking at the data all the way along. And by 2002, they decided that actually it seems to do more harm than good. The death rates were not lower, they were higher, and this was bad. And there were all kinds of scary headlines that came out. These are a couple from Canada, a couple from the US and around the world. HRT linked to cancer and stroke, doctors demand drug restriction, expert panel backs HRT warning, hormone alert, etc. Huge scare. Patients stopped their hormone therapy very, very quickly. And a lot of them, to their detriment, had very significant side effects. And we were kind of stuck, and everyone was scratching their heads going, we thought HT was supposed to be good for women. We had all this evidence that said it was good for their heart. What went wrong? So we spent the next 20 years, and it's still ongoing, but there's been a lot of time and effort put into unpacking the WHI and figuring out what happened. So what was it? It was a very large and a very well-designed study. So in this time of COVID, everyone's hearing about studies and randomized control trials and how we analyze data. This was a very, very well-designed study of a very large number of women. So those are two really good things. The design was good, the number of women was good. It compared hormone therapy to placebo, which is what you want to do to be able to say that something actually makes a difference. You need to compare it to a placebo. But it was stopped early because the study showed an increased risk of breast cancer. Now, if we're honest, we knew that was going to happen. And what the WHI was meant to do was to give us a number for that risk and hopefully show that that risk was real, but very small. And that's actually what it showed. So that wasn't unexpected. But it also showed a higher risk of stroke and blood clots, which was actually not entirely unexpected because we know hormones do increase your risk of blood clot and stroke. We see that in the birth control pill world, but the risk is very, very, very small. But the big shock is that it showed an increased risk of heart disease, and that was totally unexpected. And that's what led to the higher death rate. So then the question is, well, what did we miss? What wasn't the WHI? And here's the big problem. It wasn't a study of newly menopausal women. So the big mistake when the study was designed is that we said hormone therapy is great for women. They seem to live longer. Let's give it to all women after menopause. And that actually doesn't work. So the average age of women in the study was 63, and only 40% or less than 40% of women were within 10 years of the onset of menopause. And this is the key. Hormone therapy has lots of benefits, and we'll talk about that more, but it's only if it started within the first several years after the onset of menopause. If you give it later, it makes a big difference. So what happened? Three things. Age matters. You can't be starting hormone therapy long after menopause has occurred. That's when you're going to get into higher risk, especially with respect to heart. The second thing, though, is that the composition of the hormone therapy matters as well as the route. So what kind of estrogen and progesterone we give and how we give it, whether it's by mouth or through your skin, probably makes a difference with the risk. And the third thing is that overall mortality matters to some people. So it's very reasonable to say, if I do this, am I going to get breast cancer? Does it increase my risk of breast cancer? But it's also very reasonable to ask, am I going to live longer even if I do get breast cancer? And everyone has a different approach to that, but I think that needs to be taken into account. So to unpack that a little bit more, we now know, and this is pretty clear, that the heart benefits are very good for women if they start menopause within 10 years, if they start hormone therapy within 10 years of menopause. They have fewer heart attacks. They have fewer deaths related to the heart. And interestingly, if you started at a younger age, there is no difference in stroke risk. So there is a stroke risk if you take all comers from age 50 to 70 something, because older women are more at risk of stroke, and the added risk of hormone therapy bumps it up a little. But younger women are at lower risk of stroke, and the added risk of hormone therapy isn't significant, and we don't see higher rates of strokes. So I mentioned before the composition and the route matters. So what the hormones given in the WHI were actually a lot different than what we use now. In the WHI, they use something called Premarin and Provera, which for many years were our standards. And the technical names for them are conjugated equine estrogen and medroxyprogesterone acetate. Most of what we give currently is some version of estradiol. So it's not conjugated estrogen, it's estradiol. They're both estrogens. They both achieve the same goals, but they have different chemical properties. And the progestin we use is also different. It's called micronized progestin for the most part. Both of these products probably have a different impact on breast tissue compared to the conjugated estrogen and the medroxyprogesterone. And they have different metabolic effects, which can lead to less clotting and less heart risk. The other big difference is that not always, but we often give estrogen through the skin now. And because of how it's metabolized, that also lowers your risk of clotting. So when we put all that together, it explains the age, and the formulation explain why the risk now would be smaller than what we saw in the WHI. And then the last thing is that overall mortality matters. So as I said, it is very appropriate to focus on individual outcomes. For some people, a fear of a certain risk, be it breast cancer or a blood clot, it is the driving force for them, and it will be their deciding factor of whether or not they want to proceed. But for other women, they are sort of taking a picture from a higher level, sort of an overall risk. and understanding, well, that yes, there may be a higher risk of breast cancer or blood clot. There's a lower risk of heart disease and bad outcomes related to bone health, a bunch of other things we'll go over in a second. And overall, the risk of death is actually lower if you take hormone therapy versus not. And that's been borne out in a bunch of studies since the WHI, what we call meta-analyses, which is taking a whole bunch of studies and analyzing them together to make them stronger by pooling the numbers, as well as systematic reviews. And it's shown that women who take hormone therapy within 10 years of the onset of menopause or under the age of 60 have an overall mortality benefit, meaning they live longer. So what's the bottom line? What do we don't know now, 20 years later after the WHI? So we know that hormone therapy will help your symptoms of hot flashes and night sweats. We know it'll keep your bones healthier and your heart healthier. We also know it'll decrease your rates of colon cancer, which is a bonus. It seems to decrease your rates of diabetes as well, and it will help sleep. The jury is still out, to be honest, about whether or not it helps depression and cognition, so that sort of brain fog and memory. On the risk side, absolutely, hormone therapy does increase the risk of breast cancer, but the numbers are very, very small. It will add about 3 to 4 extra breast cancers per 1,000 women after you've been on it for 5 years or longer. So the risk of breast cancer does not appear until you've been on it for 5 years or longer, not at all before then. And that translates to a less than 1% risk per year, and probably even less with the newer hormone therapies. We also know that hormone therapy absolutely increases your risk of blood clot or pulmonary embolus, which is a blood clot traveling to the lungs, and that can be lethal. I mean, this is big deal stuff. Again, those risks might be smaller with newer preparations, but the risks overall are very, very small. And as I mentioned before, it doesn't increase the risk of stroke. All right, so let's say you take all of that and say, okay, I'm really symptomatic. It sounds like this will treat me well. I get the risks, I get the benefits, I want to do it, but for how long? So most women actually on their own will just stop within 5 years. And as I said in the last slide, the breast cancer risk isn't apparent until you've been on it for 5 years or longer. So that's a great way to approach it. Take it to help you through the difficult times. And then as things start to improve, your symptoms often might continue, but they're often a lot less intense. You might find your risk-benefit decision starts to shift at that point. So 50% of women will still have symptoms at 5 years, but often they're less intense. And as I mentioned, the breast cancer risk isn't apparent for at least 5 years. And importantly, that risk goes down once you stop it. Once you stop it, though, you do have increased bone loss. So you start to lose the bone at a more rapid rate, the way you would have if you hadn't taken it in the first place. And so the bottom line these days is most of us would say, if you're on hormone therapy, consider before that 5-year mark whether you still need it. So try to lower the dose or come off of it and see if you're still symptomatic. If you are, you have an ongoing conversation about the risks and benefits, and there's no need to stop it. That's pretty well supported by all the major menopause and OBGYN organizations. Continuing it is fine. It's an ongoing discussion and certainly should be reassessed yearly and continue to review your own personal risks and benefits. Okay, what about bioidentical hormones? So I want to ask a question. What do you mean about bioidentical? Because the truth of the matter is bioidentical is a made up marketing word. Hormones are hormones are hormones as far as I'm concerned. So do you mean natural? Well, estrone is the version of estrogen that is most like what we make in our body. And the absolute only way to make it outside of the body is in a lab. It's purely chemical. It's called estradiol. So if you mean by bioidentical, you want something that's more natural, there are plant-based estrogens. The conjugated estrogen that we talked about that they used in the WHI study was plant-based. Actually, that one was horse-based, but there's a similar one that's plant-based, but it's not estradiol. It's probably not quite as healthy as the estradiols. So you've got to think about what you're really looking for when you talk about bioidenticals. There's a lot of compounding pharmacies that tout their wares. Very, very well shown that the dosing is very inconsistent. So what you get one day is not necessarily the same dose as what you get the next day. And that can be risky on both ends. Too much and too little can both have health risks. We know for sure that you can't give enough progesterone cream through the skin to protect the uterus. So that's a non-starter. And anyone who tells you that you can take your progesterone as part of your estrogen balancing component through your skin with a cream. Get away from them because they don't know what they're doing. And the last thing I'd say about all of that is many places that tout bioidenticals talk about measuring and monitoring your serum levels, your blood levels. And often, especially if you're in Canada, it costs a fortune. You have to pay for it. It's not covered. There's no role in measuring your hormones to treat your menopause symptoms. You treat to manage the symptoms. We don't treat the lab values. So I don't care what your numbers are. I want to know how you feel. That's how we approach treatment. Okay, there are a few other hormones to think about that are not specifically estrogen and progesterone. And the newest one is called Tibella, which is available in both of our countries. It is estrogen and progesterone, but it also has an androgen in it, which is testosterone is an androgen. It's, a male hormone. And that has been touted to help with sex drive and general feelings of well-being. Not totally well established, but may play a role. So that's a newer option. And then people talk a lot about DHEA, which is dihydroepiandrosterone, and I always twist my tongue trying to say that. Studies have not shown any consistent benefit from it. So I'd say don't waste a ton of money on it. And we don't have it available to us in Canada anyway. There is a vaginal DHEA, which is good for vaginal symptoms, but that's only available to you guys in the States. And then there's always conversation about using testosterone or androgen specifically. And there is definitely some benefit for women, postmenopausal women who have what we call hypoactive sexual disorder or dysfunction. And there's another sort of subset of that called female sexual arousal disorder. The problem is those diagnoses are very, very hard to make. And in really well done studies, they're very, very rare. Well, I'd say uncommon. I won't say rare, but uncommon. Most women who have sexual dysfunction, it's very multi-layered. There's lots of reasons for it. And a lot of it has nothing to do with our hormones. It has to do with life in general and all the things that build our lives and what goes on around us. And so treating that with steroids isn't going to help because it's not going to fix all those other problems. And we certainly know that testosterone has not been shown to be beneficial for general well-being. So that's not a great reason to take it. And side effects can be potentially pretty significant, including virilization. So that male sense of lowered voice, hair growth, and it's definitely bad for your cholesterol. So it can increase your heart risk. In Canada, we don't actually have an approved preparation for women, although we do have testosterone available for men, and we can manipulate it and give it to women that way. There are some other things that are reasonable options for treatment that are prescription. So you've got a category of antidepressants called the SSRIs. You probably have heard of Cipralex, Lexapro, Effexor, and Paxil. They're pretty good at treating hot flashes. And a lot of women, I'll see this often, that women will have been on an SSRI and then they come to see me for their hot flashes, and they're actually a few years out from menopause, and their hot flashes seem to have gotten worse, and they don't realize that they were on something like an SSRI that was helping it a little bit before. The other one that's actually quite good and almost as good as estrogen for the hot flashes is gabapentin or pregabalin, which is known as Neurontin. It's a drug that comes from the neurology world and is used in a bunch of scenarios. Often women are on it if they have chronic pain problems, or men for that matter. Works really well for hot flashes. It can make you extremely sleepy. So that can be a problem during the day. But if the symptoms are bad at night, and especially if sleep is disturbed, it could be a great non-hormonal option. And then lastly is something very, very old school called clonidine or Dixerit, which is available in Canada. I'm not sure about in the States. Pretty good for hot flashes, but it causes dry eyes and dry mouth. And that can be really, really uncomfortable. It's usually enough that people aren't willing to continue it. So that's all sort of the prescription stuff. Now there's a whole other category of botanical therapies that are talked about for hormone therapy. And what you need to remember is that the placebo effect is real. And this is true beyond hormone therapy and all of medicine. Very, very well established that if you take something and you want it to work, you believe it will work, you hope it will work about 30% of the time. And this is true for placebo for vasomotor symptoms, so for the hot flashes. So on their own, black cohosh, soy, St. John's wort work 30%, same as placebo. There is some evidence that if you combine black cohosh and St. John's wort, it might be a little bit better, but there's a lot of drug interactions with St. John's wort. So you've got to be very, very careful. The ones I would totally stay away from are dong quai and ginseng. They have some serious drug interactions. Ginseng can make you bleed quite excessively. So avoid those. Evening primrose oil has been out there forever. I think it's completely benign. I don't think there's anything bad that can come from it, but there's zero evidence. I've looked at a ton of studies, no evidence that it helps at all. So don't waste your money. And then wild yam and ginkgo have also been thrown out there, no benefit. Acupuncture doesn't seem to help, unfortunately, no better than placebo. A psychology approach with cognitive behavior therapy doesn't seem to help, although there was one pretty good study that showed it was helpful in women with breast cancer who are going through menopausal symptoms. Hypnosis may have some benefit. And exercise, unfortunately, which I tout for all kinds of treatments of things because it releases natural dopamine, which is so helpful to our general sense of well-being, doesn't seem to help for hot flashes. Yoga may be the one exception to that. So that's all for the hot flashes. For the depression, St. John's wort might help, but like I said, you do need to be careful with its drug interactions and also with anesthetic agents if you're having surgery. And valerian root might be a little bit helpful for sleep disorders as well. And then for sex drive and vaginal dryness, painful sex, these products, soy, chastaberry, ginseng, have all been sort of put out there. Not a ton of evidence. Often they're mixed with other things. Chastaberry can have pretty profound hormonal effects, so you do need to be careful. And the ginseng has a potential for bleeding problems, so be careful about taking it or how much you're taking. There's a bunch of products that take the botanicals and then put them in a package and call them hormone therapy or call them menopause treatments. So Remifemin, Promensil, and Femoral are all available, I believe, in Canada and the States. They're all combinations of a variety of botanicals. Again, not great data, but placebo is real. And my perspective is as long as what you're taking is safe, and if you feel it's helpful, go ahead. We want you to feel better. So just be aware of what's actually in it and make sure it's something that is safe. Okay, so the part that I want my parents to turn their screen off for, genitourinary symptoms of menopause, or what happened to my vagina. So GSM used to be referred to as urogenital atrophy or vulvovaginal atrophy, and atrophy is a word that means dried up. Not a nice word. So we've changed it, genitourinary symptoms of menopause, which is a little more all-encompassing because it involves the genital area as well as the urinary or bladder area. What happens is that after menopause, and it can happen even before, but this typically is after menopause, the skin in the vagina and the vulva starts to change. It gets thinner. It loses its elasticity, its ability to sort of expand, and you lose those, what we call rugae. So those are the rolls in the vaginal skin, which expand when you're having sex. And with that, you often get less natural discharge and lubrication. There's my first typo, lubrication. It should be lubrication. So all of that leads to pain with intercourse. It can lead to a burning and itching sensation. It can lead to cracked and bleeding skin. Very, very uncomfortable. Now, I mentioned earlier that the vasomotor symptoms often get better over time. The vaginal symptoms go the other way. They tend to start and then they slowly get worse over time. I've seen women who didn't become symptomatic until they were 70 or 80, so years past menopause, and then it finally catches up to them. Along with that, you can have some bladder symptoms, so urgency, like a sense that you need to go all the time, and frequent bladder infections. And as well, women often don't report these symptoms. So they suffer in silence, and physicians don't often ask. So if women don't say it and we don't ask, nothing happens. And these, sadly, are very easy to treat. So we do want to talk about it. So yes, it can be better. We've got lots of really, really good options. And the first, just like with the menopausal symptoms, estrogen is going to be the most effective. The big difference is that you can put estrogen in your vagina and it stays in your vagina. So we call it local or topical estrogen. It means it's for the vagina only without getting into your whole body. It actually works better that way compared to taking it as a pill. So if you take an estrogen pill, it will help your vagina. putting estrogen in your vagina will help more. And the good news is you really don't absorb it into your body to any significant extent. So we've done lots of studies looking at the blood levels of estrogen in women who are taking estrogen in the vagina compared to women who are not, and the blood levels are essentially the same. Now, some women will still feel a bit of a difference, whether that's the placebo effect or just your body getting used to it. We don't really understand because their blood levels are low, but you can feel a little bit of breast tenderness or nausea, especially when you first start to take it. And the way I like to explain it to patients is local estrogen or topical estrogen is just like a steroid cream. If your doctor gave you a prescription for a steroid pill, that's a really big deal. That's a serious medication. It's not taken lightly, and your doctor's certainly not going to give it to you lightly. But a steroid cream you can buy at the pharmacy without a prescription and use it whenever you want to. Local estrogen is like that. It's just in your vagina. It's not getting absorbed into your body the way a topical steroid cream isn't getting absorbed into your body. So it doesn't have the same risks. Having said that, and I don't know if this is true for the States, but certainly in Canada, when you get a topical estrogen product for your vagina, and you read the patient information insert, it lists all the same possible risks and side effects of estrogen that it lists for the pills that you would take or the cream that you would put on your skin that does get absorbed into your body. So you do need to be careful, because I've had many patients, we have this whole conversation, it's not getting absorbed into your body to any great extent. There aren't the same risks. And then they read what's given from the pharmacy and they get scared and they don't want to take it. So I do like to warn patients about that. So there's a few different prescription options. There are tablets of estrogen you can put in your vagina. There's a ring and there's a cream, a couple different creams. The creams are pretty messy and some of them are actually a little bit smelly, but if the symptoms are on the outside around the vulva, it's a lot easier to get the cream applied to that area. So it can be helpful in that sense. The tablets are called Vagifem, pretty convenient. You have to insert it twice a week, every day for the first couple of weeks, but then twice a week. And it can be very, very helpful. And then the S-ring is a flexible silicone ring that you put inside your vagina and you leave it in for 3 months. It's kind of a do-it-yourself treatment. You put it in, after 3 months, you pull it out and you put a new one in. And for women who have a little bit of a droopy bladder, they feel like things are dropping, especially if you've had some children, that ring can kind of give you a sense of support, like it's being held up. And you can have sex with the ring in. Some people like it, some people don't. You can put it out, take it out, leave it on the bedside table, put it back in when you're done. So they're all good options. But importantly, if you do start these options and they help, don't stop it, because if you stop it, the symptoms are going to come back. There's a couple non-estrogen options that are available in the States, not in Canada yet. One's called Asphema, which is actually a pill. So you swallow it, but it is a designer estrogen. It's designed only to work on the skin and the vagina. So even though you're swallowing it, it doesn't work anywhere in your body except in your vagina. And Intrarosa is DHEA, just for the vagina. You put it inside, and it's pretty helpful as well. So those are a couple good options. And then there's some non-hormonal options. So there's some moisturizers that you can use, and I would look for something with hyaluronic acid or glycerin. Lots of different products out there, and you use them twice a week. And then, so I call the moisturizers, starts with an M. It's a moisturizer. It's for maintenance. You need to keep doing it routinely to keep things good. But for anything that involves putting something in the vagina, like sex or any other activity, you want to use a lubricant. That will really help. And especially if you're having symptoms, the water-based lubricants can be kind of irritating because they actually dry the skin out. So you want to avoid the KY jellies and Astroglide and find something that is more silicone-based. But the simplest, cheap and cheerful, is coconut oil from the grocery store. Works great. And lastly, laser, really, really helpful. I've got a ton of patients who've done it, especially those who can't take estrogen, and they found it very, very helpful, but it can be very expensive. Okay, last couple things. Women who've had breast cancer, they still go through menopause. Often they go through it earlier because of their treatments. And sometimes their vaginal symptoms can be extremely debilitating. And local estrogen, so estrogen in the vagina, is acceptable to many cancer doctors because there's so little that gets absorbed into the body that it doesn't make an impact on their breast cancer risk. Laser can be highly effective. As I said, I've got several patients who've done it very, very successfully. And occasionally we use hormone therapy by mouth, so through the whole body, for women, even if they've had breast cancer. This is a very select population. Typically, it's women who are very symptomatic. They've failed all other options. And it certainly depends on the kind of breast cancer they've had. And it's very much a conversation with their oncologist. So that's not for everyone by any stretch. But if you're really symptomatic, it's worth a conversation. And then also, obviously, the non-hormonal options for breast cancer patients, the antidepressants and the Neurontin can be very, very helpful. There are women who go through menopause early because their ovaries are removed, and we call that surgical menopause. You can't compare what we know about hormone therapy risks in older women to younger women who become surgically menopausal, because if our ovaries are still in, they would actually be producing much higher doses of estrogen and progestin. And we know that if you go through menopause early, it is associated with death at a younger age. So there's actually really strong evidence that tell us to encourage the use of hormone therapy for women who become surgically menopausal at a younger age, at least until a more average age of menopause. And women who have a family history of breast cancer or women with a BRCA gene. So I'm gonna take these two separately for a second. So the BRCA gene is a breast cancer related gene, breast and ovarian cancer, and it strongly increases your risk of breast cancer. And in fact, it increases it so strongly that the added very, very tiny risk of breast cancer from hormone therapy becomes washed out. It's unfortunately like a drop of water in a very, very large bucket. So women who have a BRCA gene absolutely can take hormone therapy if they need it. And certainly a lot of those women have had their ovaries removed because of the ovarian cancer risk and go through menopause at a very early age. So it's very important for them to take hormone therapy, not only for symptoms, but for their overall health and well-being and life and living. A family history of breast cancer is a risk factor potentially for your own breast cancer risk. But again, if your family history is significant for you, that is a much, much stronger risk than hormone therapy. And the added risk of hormone therapy is essentially negligible. Now, having said that, this gets to what we talked about before about individual risk versus overall mortality risk. There are women who say, I know hormone therapy will make me live longer, but I've watched my family member go through breast cancer. I will do absolutely nothing ever, never that may increase my risk, even if it means something else might happen. Totally fair. But certainly a family history of breast cancer is not a contraindication to going on hormone therapy, but it's a conversation for sure. Okay, and lastly, before we get to some questions, here are some resources. We'll put this out through whatever mechanism Jude and Nancy are putting it out, but the North American Menopause Society is my go-to. If you want one, that is the go-to place. The American College and Society of Obstetrics and Gynecology of Canada are also both excellent in terms of resources, as well as the British Menopause Society. And the last one, the Menopause Manifesto, I feel like I'm on a book tour with Jen Gunter. I will admit I haven't read it yet because it literally came out last week. Jen Gunter is a pretty prolific Instagrammer. Some of you may have heard of her. She wrote the Vagina Bible. She has no problem challenging, self-made experts like Gwyneth Paltrow, who say ridiculous things about what to put in your vagina. And she's pretty funny about it too. She's a little bit wacky, but she is an OBGYN. She actually I trained with her. I was a med student when she was a resident. She is Canadian, but lives in the States. So we can both take ownership. And she is excellent at distilling the science in a very understandable way. And she's got a very out there approach with very mainstream information. So I really trust what she has to say, and she's a great reference. So you can look up her book, and she's got lots of articles. She's been in the CBC and the New York Times and all kinds of places lately. So those are some go-tos. Okay, so having said that, this is, as I said in the beginning, a huge topic. We could go on about each portion of it for a very, very long time. I haven't even left as much time as I wanted to for questions, but I do think we have some time. So I'm going to hand it over to Nancy to moderate.
Elise, thank you. A little scary, I won't deny that, but a lot of information. So let's start unpacking a couple of the questions. Okay, Robin asked, 2 drinks a day, ? All drinks, including wine? There's a couple people unhappy on my text about the 2 drinks a day there.
I won't tell you the number of my friends who texted and saying, I poured myself a glass of wine and now I'm ready to listen. I'm like, oh, you're not going to like what I have to say. Yes, two glasses of wine is a much higher risk of breast cancer, increases your risk of breast cancer more than hormone therapy, definitively. No one will challenge that. We take all kinds of risks in our lives, right? And it's all about perspective. And that's hopefully what I'm trying to give you here is some perspective.
Okay, next question. This is from Atlanta, Carrie. If mother had estrogen-based breast cancer, is taking birth control pill to control rupturing ovarian cysts safe to stay on? The pill seems to be working well.
Yes. That's the short answer. Carrie, I can give you a longer answer later. But your ovaries are making, if you're not in menopause yet and you're making ovarian cysts, your ovaries are still making lots of estrogen. You are sort of moderating how that estrogen comes out by being on the pill. You know, you have a family risk. That risk is there. Breast cancer is stupidly common. I mean, we all know, I'm sure, more than one person, friend, family member who has had breast cancer. Our lifetime risk is somewhere between 1 in 8 or 1 in 9. So I don't know how many people are on this call right now, and taking my dad out of it. If everyone else are women, look around. 1 out of every 8 screens will get breast cancer in their lifetime. So of course you're going to see women who've been on hormone therapy who have breast cancer, who've been on the pill who have breast cancer, because breast cancer is really, really common, unfortunately.
Okay. I think you touched this, but let's do it anyway. This is from Jude. What about if you have no uterus, but still have your ovaries? Do you recommend HT?
Okay, so first of all, if you have no uterus, a lot of women think if they have no uterus and they stop getting their period, they're in menopause. They're not. Your uterus is purely a vessel from which to bleed and grow babies. Your hormones come from your ovaries. So if you had a hysterectomy and your ovaries are still in, you're not in menopause. You will go through menopause at some point. And if you are one of the lucky ones who has very few symptoms, you won't even know when that was. But if you are symptomatic, that's perimenopause leading into menopause. And hi, everyone. You can take estrogen only. You do not need progesterone. So estrogen only. And in fact, this is a whole other sub talk from the WHI. Women who had estrogen only because they had already had a hysterectomy actually had an even lower risk of heart disease, of breast cancer than women who are on estrogen and progesterone. So absolutely, you can take hormone therapy and you only need estrogen, and you can even take a deeper breath and say, okay, my risk is even smaller.
Okay, from Aviva, is there any risk to not taking hormones?
Yeah, I mean, that's a great question. So a lot of people, you know, the pendulum swings on hormone therapy. It used to be the greatest thing ever, and then it was the worst thing ever. And there's actually a 20-year set of women who went through menopause. I would say, Nancy, somewhere between us and our mothers, that generation in between, really missed out. They weren't treated, and arguably they lost out on the heart benefits of being on hormone therapy. I don't think we're there yet in terms of saying people should go on hormone therapy even if they're not symptomatic, because it is good for the heart and they live longer. But I've had patients who've asked me that question, and I have a full conversation with them about risks and benefits. And if they then choose to go on it, I don't have a problem with that.
Okay, Sandra had a nice little editorial comment here, which I liked, and it said if men had hot flashes, hormone treatment would be free in an instant, and she's right.
So would all the treatment. Well, this is the interesting thing. Men are impacted by the GSM, by the genitourinary symptoms of menopause. It is shocking to me that that is not better acknowledged, treated, talked about, and covered.
Okay, Lori Sugarman, does family history of breast cancer on dad's side equal on mom's side?
Oh, that's a very good question. So technically, yes. Well, sorry, let me take that back. Yes, you're not talking about family history of a male breast cancer. Yeah, if there's a family history of breast cancer, then the risk is there. It doesn't matter which side it comes from. But it's obviously getting a bit further away if it's not your father who had breast cancer. Men can have breast cancer, and that is a huge risk. There's probably a genetic link if your dad had breast cancer, if there's a male breast cancer in your family. If it's on the dad's side and there's a lot of it, that is a risk for sure.
Okay, Karen recommended the Vagina Bible for anybody looking for another book.
That's the same author. That's Jen Gunter.
Okay, is that Jen as well? Okay. Cheryl.
Like me, she started younger and moved into menopause.
How common is it to get a surprise period? Oh, what a surprise. Fun. Once you're in menopause, and what could it mean if all the tests, including a biopsy, come back negative?
So very, very common. It's probably like a third of what I do in my office. So you got to be careful about what you're calling a period. Just because you bleed does not mean it's a period. A period is a definitive bleed as a result of a shift in hormones, estrogen, then progesterone, and then it drops. That's a period. So menopause is 1 year after no period, but I've seen women who have had one more egg released and they've had a period. And so that could be what it was. But there's a gazillion other reasons you could bleed after menopause. The lining of the uterus could be a little bit thin and atrophied, that dried out word, and it just breaks down a little bit. You could have a polyp, which is almost always benign and nothing to worry about. It could be from the vaginal skin. That when the vagina gets drier, it can bleed. So yeah, you have your biopsy. We make sure it's nothing bad. We can't always tell you what it is, but we can tell you what it isn't, and that's fine.
Okay, so, okay. Any other questions? You're more than welcome to unmute yourself and ask a question. We're at 8:30. I want to be respectful of time, but just in case, if anybody has any extra questions, we've got a little happy to go over a minute or two.
Okay, why do some women breeze through it? They have one little hot flash, that's it, it's over. And other women, like me, 30 years, 30 years.
No answer for you, Sandy. Sorry.
Sorry.
We don't know. It
Doesn't
actually-
matter, it's finished, but you know.
In fact, that is some of what I've read in Jen's book, is she tries to address that, and she's looked into it more than I have. We don't know. We don't know why some women are so sick. Now, having said that, there's actually some new data coming out on life experience at a younger age and various experiences and traumas, et cetera, that might impact how challenging different life stages are. But I don't think that fully explains it.
There's a question here from Leslie Pecker. Is there any long-term benefit from hormone therapy in treating osteoporosis? I understand that there's bone loss after stopping hormone therapy.
Yes. So that's also very, yes, there is. The answer is yes, there is. But whether it's enough, given that there are other good options for treating bone loss, if you have it, whether that's enough of a reason to stay on it forever and ever, if you don't have other reasons like symptoms. But certainly if you are symptomatic, and bone loss is an issue as well, staying on it for those two reasons is quite reasonable.
Any other questions? There are a couple thank yous in here, Elise. People are thanking you. Oh, wait, we've got more. Any issues with eating chocolate and increased symptoms, other diet tips beyond red wine and caffeine?
Chocolate, no. Chocolate actually can be helpful for PMS symptoms, or sugar can. I have never heard or read that chocolate increases symptoms, but listen to your body. If you find your hormone symptoms get worse with certain things, then switch to white wine.
That's good news. I like that too, by the way. Is there any concern with going on it for 3 to 4 weeks and stopping for 2 months and starting it again? Any issues?
Yeah, not really. I mean, in theory, the clotting risk, starting and stopping increases your clotting risk, but the risk is so small anyway that it's probably not significant. But you wouldn't want to do that as a long-term strategy. Like, go on, go off. It does take, I should say, it takes a good 2 months to sort of settle in. Most women, when they start it, will feel better pretty quickly, but the full effect will take a few months. So if you are going to try it, stick with it for 2 to 3 months before making a decision about whether it's working for you or whether maybe it's not working enough and you need a slightly higher dose. That's something else we've done since the WHI, is we start on a lower dose than we used to, and then we go up from there rather than starting on what is the normal dose. Is it's not high dose, but we can start even lower and it usually works.
One more question. Will hormone therapy help with weight loss? Other symptoms are low.
For some people, yes. For some people, no. Definitely yes for some, definitely no for others.
Okay, I have a question for your mother who looked like she was taking notes. So I want to know, Marilyn, were you taking notes here, and are you going to give this session to your friends? She's on mute. You're on mute.
one of my friends is on, another couple couldn't get on for some reason. Yes, I might pass it on. The stuff that relates to old timers like us.
All right, so it's going to be recorded and there's a link above, and if your daughter doesn't send it to you, I will send you the link so you can have
Okay.
access to it. You don't have to send your notes along, okay? But I noticed you scribbling away there and it was adorable. So any last questions before we go? All right, Elise, who would have guessed 30, 40 years ago when we met, you'd be doing this tonight, huh?
Seriously, right? Look at us now. Look at us now.
Look at us now. Everyone, thank you so much for joining us. We want to thank Elise for taking time out and doing this. She doesn't normally do it to us lay folks. She gives this session often, but mostly to her fellow doctor friends. And so we thank you for bringing it down to us. I know there's a bunch of great information in the deck, which we'll post. And, you know, I think she would probably say, go speak to your doctor, do a little research and figure out what's right for you. I have at least one person from Montreal, you know, commenting on your presentation. So at least we'll be talking again, no doubt, about this. So look, we hope it's helpful and that everybody, you know, thinks about how to manage this and think about it. There's some younger folks on this call who are now sitting here thinking about what that means for them. So I think we had some really nice ranges of ages here. Hope you all enjoyed the program. There will be a survey going out tonight, early tomorrow morning from Jude. We have one more session coming up on the 16th in the middle of the day with Hadassah. What's her last name, Jude?
Margolis.
Hadassah Margolis. She's fantastic. So please join us and go to womanology.org if you'd like to. That's June 16th on healthy living. How are you? A loaded question. And thank you so much for joining us. We have one more session left and it appears Cooper is done for the night. So he has decided you're done too, Elise. So thank you
Thanks,
all. Have a
everyone.
great night.
So nice to see everybody. Thanks for
Nice
logging
to see
in.
you. Thanks for joining us tonight. It's been fun.